Hello everyone, it's Hunter Hicks. Today we're going to look a little bit more at just some basics of the pregnant patient, just some things we want to be looking out for. We'll talk a little bit about anatomical changes, hormonal changes. We'll talk about medications, vaccines, nutrition, and then some common complaints we might see. Again, pretty basic video here, but I hope it's helpful. So a couple things, when we're looking at the estimated delivery date for our patients, we generally say that this delivery day is going to be 40 weeks from the last menstrual period. But we can also calculate this by using our estimated delivery date equation, which we're going to add 7 days, minus 3 months, and then add a year. Now, that can be helpful. However, we know that there's a lot of things that may cause changes in the menstrual cycle. So that can totally affect this date as well. And some patients might not have regular menses on a 28-day cycle. They might be longer, they might be shorter, they might maybe they were on birth control during this, maybe they have amenorrhea or different causes of abnormal uterine bleeding or stuff like that. So the best way we can definitely obviously confirm is things like ultrasound and measuring the fundal height and stuff like that. Their gestational age, basically how old they are, is relatively going to be weeks since last menstrual period as well, so these kind of coincide. When we look at just the trimester, it's very easy here. We know 1 to 12 weeks is first, 13 to 26 is second, and then above 27 weeks would be that third trimester. Now, when we're taking in a pregnant patient, a nice history that we can get here is the GP-TPAL. Some people just do the GP, but obviously there's more to the story here. So gravida is going to be the number of pregnancies they've had. Any pregnancies, anytime they've been pregnant, we're going to get a gravida. Para is going to be the number of viable pregnancies. So viable really we say is above 24 weeks. Term is going to be obviously term. So these are pregnancies that are carried to about 37 weeks. Preterm is going to be anything from 20 to 36 weeks with 6 out of 7 days. Remember, usually preterm is really everything before 37 weeks, relatively. Abortion, I'm so sorry, that says absorption. That should say abortion, is going to be less than 20 weeks, so that can be a spontaneous abortion or possibly a planned abortion. And then living is just the amount of living babies they have or kids they have. Now with twins, sometimes this is a common mistake. Remember, twins would be one time they were pregnant. They had one viable pregnancy, they had one term pregnancy, but they have 2 living kids. So twins, again, if we were to say that she only had these 2 kiddos, she'd be a G1, P1, T1, L2 if everything went according to plan. Now, some anatomical changes. When we look at blood work, a lot of these changes we're going to see are just from large hormonal changes that are going on. So we know in that luteal phase, the second half, after 14 days of ovulation, we're getting this luteal phase, right, where we have the corpus luteum that's releasing a lot of our estrogen and progesterone, which is making the endometrium in the cervix, endometrium in the uterus ready to go for a baby. Now, obviously, over time, that trophoblast gives us more HCG, and then the placenta kind of takes over that job. But biggest thing I'm trying to say here is we have a lot of progesterone levels, a lot of estrogen levels going on here, and that's where we're going to see a lot of our changes. So blood work, right away we have increased risk for clotting for these patients because we know that estrogen is related to increasing clotting factors like 10, clotting factor 10. So we know that there is overall increased risk for clotting here. So we want to be watching them for any types of clotting factors that might be going on, like DVT or just a venous thrombosis or pulmonary emboli or anything like that. It's kind of the same idea where we see the same risk sometimes with ladies on estrogen forms of birth control. Other things we can see is overall this hemodilution. So we see a huge increase in the plasma content of our patients. The idea here with that is they're just kind of increasing the needs of the baby. So we see a huge plasma content, so they have a lot more fluid on board, so they can actually lose a lot of blood loss until we actually see signs and symptoms of blood loss. That's something important to see if you're dealing with patients more on the high-risk OB side and they have postpartum bleeding, so it's something we want to be watching there as well. But this dilutional This dilutional anemia can make them look anemic, so their H&H might appear low because they have so much plasma on there as well. Iron levels can be low. That's just from this quick turnover of erythrocytes because we're making so much, whether that's for the developing baby, the placenta, all those things that are going to require more and more erythrocytes. Creatinine should actually be low, so creatinine clearance, we know that's a common thing we look at our elderly patients. Their creatinine clearance usually is slower because they're decreasing renal status. However, here we see increased renal perfusion, so we actually see a increased creatinine clearance, so their creatinine should be low. That's the other reason why when we're dosing medications in this patient population, their renal perfusion is going to be like really, really, really high, so maybe they can metabolize them faster. Kind of like what we see with babies when their metabolic metabolism is really, really high up to about a year. CO2 overall is going to be lower, and what I mean by that is total partial pressure of CO2 in the blood, so PCO2. The reason for that is progesterone is actually going to stimulate increased respiratory rate and higher tidal volume, so they're going to naturally be breathing larger and more faster, so their CO2 is going to be lower, and they get a little bit of release of bicarbonate, so they kind of live in a pH of alkalotic. They kind of live in alkalosis, which is pretty normal for them. Now, this can make them short of breath just because the progesterone is stimulating that, but also they feel short of breath because the diaphragms later on in the third trimester is going to be pushed up by that baby. So that might actually push on the lungs, decrease our compliance of those lungs a little bit. Therefore, they might feel a little short of breath. Thyroid, it's not abnormal for your thyroid to be thyroid levels to be higher in these patients, just overall because of the hormonal changes. D-dimer is going to be falsely high in here. Well, I shouldn't say falsely. It will be high. Remember that D-dimer is a part of our fibrin degranulation products, or FDPs. D-dimer is one of those. So every time we have a fibrin or a clot made, we know that plasminogen and everything breaks that down eventually. So we break that clot down. Every time we get a clot formed, there's other things that want to break that clot down. Well, we can see D-dimer obviously with patients that have risk for PE and stuff like that, but the hard thing is any kind of inflammatory state, or this state we see with our females where they're kind of in this large state here, they'll have they'll have increased D-dimer, so it makes it kind of harder to try to rule out a PE. Obviously, you're going to look at other things. Anatomical changes, when we look at the belly, we can obviously have this dark brown line we talk about. We commonly see that. We can also see the mask of pregnancy, kind of those brown pigmentations on their face as well. As far as the uterus, we know our uterus can be in three different kind of anatomical positions, but what we see most commonly here is it's anteverted, which means it's going to kind of be pushing up on the bladder, and that's a huge reason a lot of our pregnant females have urine, they feel like they need to pee all the time, and that's just kind of sometimes from that bladder pushing up. Some other signs we can see, Chadwick's sign is going to be that kind of blue, that blue hue that we can see sometimes on the cervix. And other areas, just because of the increased vasculature and the increased vascularity that we see from that huge progesterone and estrogen levels we're getting into the endometrium. The Hager sign is something we can see, which is going to be kind of softening of the isthmus. Remember, the isthmus is that narrower portion there of the uterus leading into the cervix. Leukorrhea, so a lot of times we can get vaginal discharge here in pregnancy. The white, if it's white kind of discharge, that's going to be more normal here, but not to mention we still want to be looking out for any kind of purulent drainage or any kind of foul odor drainage that could be a possible STI. Some other things we can see, heart huge here, right? So we worry, blood pressure is big in these pregnant patients because it can be life-threatening sometimes. What we're talking about is preeclampsia and eclampsia and HELLP syndrome. But in general, when we look at the heart, we have increased cardiac output, about 50% more. Overall, when we look at blood pressure, it's going to drop by the second trimester. So we kind of see this relaxation going on, and it actually should drop, so they naturally have lower blood pressures. But we need to be aware if they have high blood pressure. That's really not supposed to be normal in pregnancy, right? We know it's supposed to be low. So anytime you have high blood pressure in pregnancy, that's really kind of alert you a little bit. So Chronic hypertension above 140/80 would be that they're coming into pregnancy already with a high blood pressure, right? So before pregnancy, they already had high blood pressure, and we established that. Now, when we look at gestational versus pre-E, gestational is that they're going to have high blood pressure not before, but only during gestation, obviously, gestational, and it's going to be after 20 weeks. So they get that high blood pressure after 20 weeks. However, they're going to be absent of any of those signs of pre-E, which is like proteinuria, any increase your liver enzymes, low platelets, any of those HELP syndromes, anything like that. Then preeclampsia, obviously we need to confirm that with 2 different blood pressures, usually about 4 hours apart. And when we look at that, they're going to have other common signs and symptoms of preeclampsia like proteinuria and many others, but we're not covering that today because that's a high risk thing that we're not doing. Murmurs are pretty common in pregnancies, and by murmurs I mean systolic murmurs. You're not always going to hear them, but if you do hear systolic murmur, more common to see. Diastolic murmurs, never a common thing to see in pregnancy. When we look at the belly, sometimes quickening we can see in the second trimester-ish. Quickening is kind of the movements felt by mom. She can usually feel that around 18 to 24 weeks. That should be 18, not 8. And the mom can feel it. As far as fundal height, again, another thing we can confirm the gestational age. We're going to measure with a tape measure from the pubic bone, okay, all the way to the top of the uterus, which is what we call the fundus, on the top of the uterus, that dome there. Right around 24 weeks or 20 to 24 weeks is really where we say that your fundal height usually should match the gestational age. So if they're at 24 centimeters, then we think that that baby's probably right around 24 weeks gestational age. Now, a good thing to always remember is really around the umbilicus area is when they're right around 20 weeks. As far as fetal heart rate, we can detect that around 10 to 12 weeks. So right at the end there of that first trimester, and normal is around 110 to 160. Now, obviously, as we progress, these babies can have different kind of A cells, D cells, all these kind of things that, again, is more of kind of a high-risk thing that we're not covering today. So some common complaints we might see in our pregnant patients when they come in. Nausea is common to see early on. Fatigue early on, but then we might actually see increased energy in that second trimester. Breast tenderness is not uncommon to see. Again, a lot of this, you guys, is just from this huge hormonal release that we have going on. A lot of our progesterone and estrogen causing all this. We can see a lot of GERD just because we get relaxation of that lower esophageal sphincter from the progesterone. Backache is because we know our pelvis pelvic girdle is really relaxed here, so we might get some of those backaches here. Urinary frequency, we kind of talked about that, but the way that our uterus is actually going to be changing shape and then pushing up on the bladder. Hemorrhoids and constipation sometimes go hand in hand. Constipation is from the progesterone obviously is released and telling the smooth muscle of the uterus, not to contract. We like that it's not letting it contract. It's relaxing the smooth muscle, but it's also relaxing a lot of other smooth muscle. We kind of talked about GERD, but also here in the bowel, it's going to relax that so we get decreased peristalsis, so we can see constipation, and then we can also see hemorrhoids secondary to that, possibly. Vaginal discharge, we talked about that. Leukorrhea is going to be more common to see. You also want to making sure that you're really looking at the vaginal discharge, not making sure it's not anything else. Edema later, third trimester, we can definitely see this sometimes more common just from decreased venous return and stuff like that. Now, always want to make sure that you're ruling out edema versus your pre-E patients because we know those can come hand in hand. Now, when we look at vaccines, medication, and nutrition, so vaccines that are not okay to get in pregnancy are going to be MMR, polio, the live flu vaccine. We can get the non-live flu vaccine for these patients during flu season. That's okay. Varicella, and then shingles. As far as medication, so in general, a lot of pregnant patients are obviously on medications, like up to 2/3 or at least on one medication, whether that's for the pregnancy itself, like one of the symptoms, or it's for a chronic disease they have. So in general, we really want to make sure we're trying our best to treat the mother's disease because sometimes the risk is actually higher if we're not treating the disease. So if a mom has asthma and we're not treating the asthma, it can lead to complications with the baby big time. But when we look at medications in pregnancy, it's kind of hard to see what medications are teratogens that will cause anatomic abnormalities in the baby. The reason for that is this isn't really always study great because we're not just trying medications on pregnant women, right? That's not a good thing to do. The other thing is a lot of times if we look at animal studies, even though the animal maybe didn't have the effect on their baby, that doesn't mean it's not going to be the same for females or for female humans. The biggest thing is we know around 4 to 8 weeks is a really, really vulnerable time that these medications can cause issues in the baby. Now, in general, it's never good to do it, but that's where we know it's most vulnerable. Now, medications that can cross the placenta are really going to be anything that's lipid soluble, non-polar, and so on and so forth. But in general, it's always good to think everything can cross the placenta, everything can cross into the breast milk. So you're always looking at each medication and you're taking your time and making sure you're doing it correctly. Now, some things that we know that can cause issues are ACE inhibitors, lithium, anti-cancer, and immunosuppressive drugs can cause issues. Possibly NSAIDs that has to do with contractions, and then tetracycline is one of the antibiotics. As far as breastfeeding, again, same concept. Things that can cross into the breast milk are going to be lipid-soluble, non-polar medications. But in general, you should always think that all of them can, so you're really looking at them. One thing we can encourage them to do is if they are taking a medication that we're worried about getting into the breast milk, taking it right after they're feeding, therefore is a really long time again until that baby possibly feeds, and hopefully by then the half-life is kicked in. But that's just one idea. Some things we don't like to do, some controlled substances, not all, anti-cancer drugs, immunosuppressive drugs, lithium, and then atenolol. But in general, guys, doing a really good MedRec, looking at other medications, doing your research and looking at that. We do know that there is a very good guideline here, or ABCDX, when it looks at different medications. So A, it's a remote risk, B is slightly, C is greater, and then D and X we know both have proven risk, but usually category D have proven benefit over risk to the baby, whereas X, no way, category X drugs, we know that risk is always worse than the possible benefit. So always good to look at that list as well. As far as nutrition, some screening that we want to do in a lot of our pregnant women are going to be iron deficiency, because we know that we're just turning and burning erythrocytes, so iron can be low. And then also, which we'll call cause microcytic anemia, and then also gestational diabetes, and that a lot of times comes from progesterone can do that, and then also other hormones that are released are going to decrease or increase hyperglycemia. We know that if we have gestational diabetes, we have about a 50 to 60% risk of actually developing diabetes after pregnancy, so always want to be looking at that. Some nutrition that we want to do. Now, a lot of the prenatal vitamins should have these in there, but it's always good just to double check to make sure that they are for our patients. So vitamin D, calcium, iodine, folate's a really big one, because we know that lacking folate can give them issues of spina bifida, which I cover in another video for our kiddos, and then iron as well. Guys, that was down and dirty. I know, pretty simple stuff, but if you have any questions, let me know, and I'll see you next time.